I'm going to talk about the technical aspects of OCT, and I'm not going to be very dry in terms of physics and all those things. This is a very exciting field at the moment of technical aspects of OCT, and I think it's the most exciting field because all the new developments are coming up in this field, and I'm going to give you a tester menu of that. Just in 10 minutes, I'm going to give you a taste of it, and I'm sure we look forward to hearing in details in one of the sessions in the conference from Dr. Ziad Ali. So the fundamentals are that OCT uses near-infrared light directed at the vessel wall. That's very simple. A rotating single optical fiber coupled with an imaging lens within a short monorail imaging sheath is used for this. And by measuring the amplitude and time delay of the backscatter light, OCT generates high-resolution, cross-sectional, and three-dimensional volumetric images of the vessel microstructure. The problem is that the light travels very fast, and therefore interferometry is required for backscatter detection. And what is that? This involves splitting the light into signal and reference beams with the intensity of interference calculated according to the frequency differences between the two beams. That's the fundamentals of it. Problem is that all you know that the blood strongly scatters light and attenuates the OCT signal, and therefore flushing is required to displace blood during OCT acquisition. And the shorter wavelength of the infrared light in OCT compared with ultrasound IVUS confers greater axial resolution, but a lower penetration depth, which limits OCT imaging, particularly in the presence of highly attenuating structures such as thrombus, which is red, or lipid necrotic core. So when you see an orange glow circumferentially, and at some point you see the darkness, that's a lipid core. This is very exciting, that there are many OCT systems in clinical use going to be in future. But at the moment, Optis system from Abbott, which also provides combined angiographic and OCT visualization called co-registration, and LunaWave system from Terumo, Tokyo in Japan, which is exclusively being used in Japan at the moment. The next exciting thing is hybrid systems, which is in use at the moment for research purposes. NovaSight hybrid from Conavi Medical, it's a Canadian company, and dual sensor from Terumo. These are available OCT IVUS hybrid catheter system, which is being used at the moment for research purposes only. Exciting thing is there are many other companies at the moment trying to bring the OCT systems onto the scene, like Argus, Avenger, Canon, Dyad Medical, Forsman Medical, Gentuity, many of them. And you will see in future lots of companies coming out with that. So having looked at that, what would I change in future from technical aspects? You would say use of contrast. You would argue that I would use saline or low molecular weight dextran. We'll look at this in the next one slide. But I would say that increase the speed of OCT acquisition with a single cardiac cycle with full sampling both cross-sectionally and longitudinally. That means it will require a very small amount of contrast, with 2 to 3 mils only. Next, exciting technical development is fully automated morphology and physiology without causing hyperemia. Increase the spatial resolution in terms of micro OCT with 2 micrometer isotropic resolution, capable of identifying cellular and subcellular structures, and increase penetration depth. So let's have a look at the saline versus contrast. And you can see that the top panel is contrast and the lower panel is saline. And you can't make a difference between the two. A wonderful paper appeared last year, 2021, from Ankita Gore. And you will see here that contrast with the saline overall is good. What you see in green is acceptable, but in gray it is unacceptable. And immediately you will see the left coronary artery, it becomes unacceptable. So when the quality of imaging is unacceptable, then the calculations will be unacceptable as well. And therefore you will see from this the diameter and the area calculation has been corrected for saline. It's not been still validated. And that is why increase the speed of the OCT acquisition is the answer. What about this concept of OCT as all-in-one, which identifies the culprit lesion, automatic severity detection as well, and flow assessment called optical flow reserve, giving you the FFR equivalent. Lesion preparation guidance, because it gives you histology at the same time, that your lesion has calcium or fibrous or it's only a lipid pool, tells you what to use to prepare the lesion, and also gives you guidance for stenting, both landing zones, and of course stent optimization, which you already know about it. This is a slide from Dr. Ziad Ali's wonderful publication in Eurointervention from the state of the art, which tells about the plaque characterization with OCT imaging and OCT-derived FFR. It tells you about automated plaque characterization in terms of calcium. You can see the white calcium with details relevant to lesion preparation. You can see from there, it tells you where you need to prepare and what you need to prepare. And using a lumen profile, which is very important. As you know, in OCT, one of the most important thing is lumen profile. And using a lumen profile, the virtual OCT-derived fractional flow reserve is displayed as a colored map, showing areas of potential ischemia, yellow, which is distal to stent. And also it tells you about, within the segment, blue arrows, as well as for the whole vessel. You can see the whole vessel, FFR is here, and tell you within the stent is okay, but here is not okay. It's automated, it tells you. So what are the technical new developments? Engineering new OCT systems to increase the speed of OCT acquisition. I've talked about it. Spatial resolution, penetration depth, and OCT-based flow ratio may provide the benefit of both modalities combined together. The optical flow ratio has been developed and validated against fractional flow reserve already to determine the functional significance of coronary stenosis. The currently enrolling Fusion trial will assess the accuracy of offline OCT-based virtual flow reserve against fractional flow reserve on the Illumin Optis platform. And this offline takes only 1 to 2 minutes only. So what about artificial intelligence to predict IEL and EEL? You can see these images are all lipid, which at some points you can't see the three-layered structure, and that's where it calculates on its own and give you a reference. And that's all automated. And that's very practical. What about the next thing? You can see that the segmentation in challenging situation, A is a suboptimal quality, but immediately gives you the histology that it's all fibrous. B is a heavy calcification, and it tells you about the calcification in white. C is large lipid pool, demonstrates like the yellow one. And D is inflammatory markers telling you where the macrophages are and if it's highly inflamed, is it TICFA or not. What is optimal optical flow reserve? This is the LAD. Diffuse lesions in the left anterior descending artery. Optical coherence tomography acquired cross-section of the target lesion here. And a 3D reconstruction of the imaged vessel with a superimposed color-coded representation of the computed OCR. Again, the same, you can see where exactly the problems are, or it will give you the overall OFR of 0.83 at the distal end of the imaged coronary segment. Visualization of the mean diameter and the decline in OFR, the colored line here, you can see where exactly is the OFR is going down over the length of the imaged coronary segment. Wonderful. It's all automated to you. Same as true with automated assessment of OCT acquired images in terms of detection of the lumen contour with a continuous line, you can see that. And external elastic lamina and dashed lines. An automated detection of the extent of calcification in the next B, measured over a total arc of 204 degrees. Cross sections, reference image in D, the same image as in C, automated lesion character. So he gives you histology as well, that what is lipid, what is fibrous, and all those things. So in summary, technique and technology is evolving. Fast image acquisition is in one cardiac cycle with minimal contrast and time is going to happen. Fully automated to detect lesion, provide morphology, physiology, and histology of the lesion. Fully automated to provide lesion dimensions in length, diameter, MLA, MLD, percentage area, stenosis, etc. And fully automated to provide guidance on lesion preparation, stenting and post-stenting parameters for medium and long-term prognosis. The first step is the technology evolving to provide us meaningful clinical parameters, then testing it in randomized clinical trials before it comes out in the clinical use. Thank you very much.